Hello, everybody. Good evening. Thanks for joining this webinar tonight. As Glenn mentioned, my name is Dan Labow. I'm Chief of Surgical Oncology at Mount Sinai and started the HIPEC program here about 3.5, 4 years ago. I think it's very important for sessions like this to get a lot of information that sometimes doesn't come out during a consultation because there's a lot of other things going on, talking about the surgery, et cetera. And so this is a good opportunity for me to convey to you what to expect and our rationale behind doing this, and of course your opportunity to ask any questions that you like at the end. So just to outline what we'll be talking about tonight, first the scope of the problem, and I'm sure most people who are logged on tonight have some concept of that based on you logging on. And then the rationale behind HIPEC, why this came about, and why we think it makes sense, and we know it makes sense based on data and from the different places that do this. Preoperative preparation is important, not just for the immediate preoperative period, but also who is going to be a good candidate for HIPEC, and so we'll discuss those indications, tests that we do. HIPEC equipment and technique, just to give an idea, there's a lot of sometimes mysteriousness about it. And so just to take a little bit of that away and go over what goes on in the operating room and what happens. And then post-op management, also important. These are big operations, and the post-operative management and being in an experienced center is important, and so we'll discuss that. And finally, a little bit about our program here at Mount Sinai, our data, and then we'll have a chance for questions at the end. So a little bit of background, peritoneal carcinomatosis, and the peritoneal cavity is really the abdominal cavity where all the internal abdominal organs live. The liver, the intestine, the spleen, the stomach, the uterus and ovaries in women. And we know that carcinomatosis, which is spread of cancer throughout the abdomen, carries a poor prognosis. And this is not just for colon cancer, but of other types of cancers. I said GI malignancies, but this is included with ovarian cancer and gastric cancer, as well as other primary peritoneal cancers, like mesothelioma, some you may have heard of. Debulking surgery, which involves removing the bulk and hopefully all of the visible disease, has been shown to improve survival in ovarian cancer, and it's actually been around in ovarian cancer as a standard for a number of years, if not decades. For gastrointestinal malignancies, though, this has not been particularly accepted, and only in recent 5 to 10 years or so, and certainly in centers that do it in an experienced way, has it become an accepted form of treatment. To define peritoneal carcinomatosis, it is the metastatic or spread of cancer into the abdominal cavity. And it can be from intra-abdominal, most commonly it's from intra-abdominal organs, but it also can be from extra-abdominal sources, though this is very uncommon. Lies to the peritoneal cavity, and it is often accompanied by ascites. Ascites is fluid in the abdomen that is secreted or released by the tumors that live in the abdominal cavity. It can make patients feel bloated and have the abdomen very distended or protruding based on all the fluid in the belly. And unfortunately, the survival, median survival, meaning half the patients who have this diagnosis, often pass away in less than a year. So patients with peritoneal disease, this is somewhat old data, but this general concept of that it can come from a number of different sources, from the gastric, small bowel, gallbladder, colon rectal is very common. Appendix cancer, though a rare malignancy, is one that commonly does spread to the abdominal cavity. Ovarian cancer, mesothelioma, which is a cancer that actually starts from the lining of the abdomen. Pseudomyxoma peritonei, which is a lower grade appendiceal or appendix cancer. And this is 55, if not at this point, 60,000 more patients that are eligible potentially for this treatment, and in those patients where traditional or venous chemotherapy does not particularly have a good effect. So what is the natural history of patients who have peritoneal carcinomatosis? Well, it comes along with pain, crampy pain, because it affects how the bowel contracts and is able to move its contents forward. Anorexia, or decreased appetite and weight loss going along with that. Occasionally obstruction, either complete or a partial bowel obstruction, making it more difficult to eat. Ascites, which I spoke of earlier about the fluid that builds up in the belly. Infection can come from this because patients are malnourished and immunosuppressed, oftentimes getting chemotherapy, potentially with the carcinomatosis, and ultimately leads to the demise of the patient. So what are traditional options that have been out there? Well, surgical treatment, as I mentioned before, really ovarian cancer was the only original standard, or not original, but recent standard. Radiation therapy is particularly ineffective in that you can't radiate the entire abdomen and have a potential good effect, and therefore that's not used in general. Systemic chemotherapy or intravenous chemotherapy, again, has largely been ineffective for peritoneal tumors. Dual intraperitoneal chemotherapy, that is something that involves normothermic, or meaning at body temperature, where a port is inserted in the abdomen and then a tube inside the abdomen where chemotherapy can be instilled. We know that the chemotherapy can't penetrate bulky or large tumors, and when I say large, I mean greater than a few millimeters, and therefore just dual chemotherapy without the debulking is not particularly effective in that it doesn't get to the entire abdomen and often can't penetrate the tumors. In addition, the ports, though you can get chemotherapy through these ports, it doesn't get the entire belly, and you never know how much you're getting into the whole abdomen, whether the upper abdomen or lower, depending on where the port is placed. Hospice care, of course, is an option for patients that no longer want to pursue any treatment. And more recently, over the last really decade or so, is the advent of cytoreductive surgery in combination with heated intraperitoneal chemotherapy. So the rationale of adding the hyperthermia, we know chemotherapy can work against cancers and tumors, but hypothermia in and of itself has a direct lethal effect. And this potentiates or augments, increases the amount of the cytotoxicity of the chemotherapy on the cancers, and thus they work together better than each one alone, and that's why we use the combination. As I mentioned before, systemic chemotherapy is largely ineffective for peritoneal surface malignancies, and some of the normal side effects that you get with venous chemotherapy are spared in the patient with peritoneal chemo because you don't get the same systemic or whole body absorption. So what do we do for our preoperative evaluation? Well, it is important to do rigorous preoperative testing because this is a big operation, and of course, we want to make sure we're doing it for the right reasons and a way to help the patient. So routine pre-op testing like blood work. If patients have a primary cancer in the stomach or in the colon, an endoscopy or colonoscopy often is repeated if it's not done in the relatively near future or recent future, because we want to make sure there's no other new cancers in the colon before we go and deal with the peritoneal disease. A CAT scan and or a PET scan, often to make sure there's no extra abdominal disease, because the peritoneal chemo does not get to the areas like the brain or the lung or anywhere outside the abdominal cavity, and therefore we want to make sure we're not missing anything somewhere else. Performance status is important. This is not an operation for patients with multiple medical problems. In actuality, we don't really use age, at least at Mount Sinai, and any cutoff, but we certainly look at physiologic age, meaning if patients are healthy and elderly, then we can certainly do this, and we've done a number of patients in their 70s or older in appropriate situations. And then one thing that's important, because we know from the data, is an assessment of the likelihood of a complete cytoreduction, and I'll go over that in a moment. But if we feel, based on the amount of disease in the abdomen, that we're not going to be able to get an optimal debulking, then likely we would not go directly to surgery. So is a complete cytoreduction possible? And unfortunately, CAT scans and even PET scans, MRIs, any imaging study is not particularly good at assessing the abdominal cavity and abdominal tumors. This is because CAT scans are very good at picking up masses or golf ball size lesions or tumors, but not good at seeing things that are maybe very small or like a web that is flat, and therefore the usual imaging or CAT scan testing that we use isn't particularly sensitive. Other things that can lead to a cytoreduction not being possible is if there's extra-abdominal disease. So we want to make sure the extra-abdominal disease is absent. ECOG and less than 2 is this an assessment of performance status where patients are able to really function at a normal level outside of the hospital, and so ECOG just stands for that. Biliary obstruction is the bile duct which leaves from the liver and drains into the intestine or the gallbladder. And the reason why biliary obstruction is a bad sign, though not always, is because those areas are right next to the blood vessels that go to the liver, and debulking in an area like that is often quite difficult. Ureteral obstruction is the ureter, which brings urine from the kidney to the bladder. This has also been a traditional reason not to be able to do it, but in fact presented last year at a conference and coming out in publication, we were able to show at Mount Sinai in our series that in select cases we're able to resect or remove part of the ureter and reattach it. So I put an asterisk there in that it doesn't mean it's an absolute reason not to do it. One site of intestinal obstruction is because if there's multiple sites of obstruction, then we're not going to be able to resect too much bowel that will leave the patient with too little intestine to live. Evidence of gross disease in the mesentery. The mesentery is the area where the blood supply to the intestine goes, and if we have significant disease in the mesentery or on the mesentery, then we can't really get a good debulking, again, because the blood vessels to the intestine are involved, and if we damage those, then the entire intestine won't be viable. Small volume disease in the gastrohepatic ligament. This is the area between the stomach and the liver, and again, because critical blood vessels, etc., live there, often is a hard spot to debulk. Something that was developed and is pretty universally used is something called the Peritoneal Cancer Index, the PCI. What this does is give an opportunity to try and grade or stratify how extensive the peritoneal malignancy spread is. And you can imagine that a patient with colon cancer who has one small marble of peritoneal tumor in the abdomen and one that has 100, those patients are both stage 4, but it doesn't take a lot, by common sense, you can tell that those patients are likely going to behave different, one small tumor versus 100. And so this peritoneal cancer index is a way that we can try and assess how extensive or not extensive the malignancy is within the belly. So we do this preoperatively by imaging, but as I mentioned before, that's not particularly effective. And then we do this intraoperatively and make an assessment. And we divide the abdomen into 13 zones with a score of 0 to 3 based on the size of the tumors or lesions in that area, with a maximum score being 39. And in this case, you want the score to be low. Like in golf, you want the score to be low, not high, because a high score means you have a lot of disease all over the abdomen. A low score meaning you have less disease in limited areas of the abdomen. So the LS is the the lesion score. A 0 means there is no tumor. So in the right upper quadrant near where the liver is, I don't know if you're able to see my cursor, but you can see here 1 through 9,
10.
and then the areas of the small intestine 9, 10, 11, 12, and you can see and we grade each of those zones based on the size of the tumor, the largest tumor in there, and then give it a score. I'll just go back one moment. So the score, in general, a score of 39 is unlikely that you're going to be able to do an optimal debulking, and most would agree that a score of 39 is not a reasonable patient to take to the operating room. That being said, we can do patients who have a very low score, then there's a very high chance we'll be able to be successful. And the fact is there's, depending on where the tumors are and what the CAT scan shows preoperatively, we make an assessment on that. Sometimes we start the operation with a laparoscopy, which is a small incision where we look in the abdomen and assess whether or not the tumors are going to be able to be debulked. And if we do, then we proceed with the regular incision if it's necessary, or we sometimes back out and do other options until the patient is an appropriate candidate. So the day of surgery, like any major operation, nothing to eat or drink the night before. I often don't use a bowel prep unless there's going to be an extensive bowel surgery. There's no really great evidence that it makes a difference in infection. We do give antibiotics to the patients before surgery. This is more of a surgeon preference, and some may do it. Of course, you arrive early in the morning, and usually these operations take a long time, so we start early in the morning and sort of set aside the day. I would meet the patient in the pre-op area beforehand. Of course, we would have a consultation in the office before, but I would meet the patient before they go back and answer any final questions. The patient would then meet our anesthesiologist, of which we have a dedicated team that works on these patients with me, and thus have experience for the intraoperative issues that sometimes arise in these patients, and then we would begin the surgery. My usual statement to patients now is that they're going to be sleeping through the operation, and the family members, of course, who are sitting in the waiting room are the ones that are pacing and waiting, but we do keep them abreast of what's going on in the operating room, and of course, I speak to them after the surgery is complete. So what is our technique? Well, in the operating room, the first thing, as I said, is to look around, like in any appropriate cancer operation, is to make sure that we look around the entire belly and make an assessment of how much disease there is, what rate-limiting factors might be, whether or not this is going to be possible, and we free all of the scar tissue. That's the lysis of adhesions. That means freeing all of the scar tissue that might be in the abdomen from any previous surgery. Why that's critical is that we don't want, or we do want, the chemotherapy to get to every single spot in the belly. And so if we don't free the scar tissue up, then chemotherapy might not get to some areas where tumor could be hiding, and therefore we really take our time to make sure that every single area of the abdomen is exposed to the chemotherapy. Once we've done all the surgery, all the removing of the tumor, and this can last from a couple hours to 4 to 6 hours, depending on the extent of disease, we insert some special cannulas and temperature probes where we monitor the inflow and the outflow of the chemotherapy and make sure it's at the heated temperature before we insert the chemo into the fluid. And then we close the skin and connect them to our circuit, the Thermal Solutions pump, and then we monitor and circulate and heat. A special perfusionist is dedicated to monitoring the flow, making sure the temperatures stay appropriate, making sure the flow is appropriate, so that we have chemotherapy heated up and circulating at all times. Most centers do 90 minutes of perfusion, but there are some that report between 60 and 120, but the majority do 90, as we do at Mount Sinai. And then once all the perfusion is done, we remove the chemotherapy fluid, wash it out, and then we complete any bowel connections that might be necessary, and then close the abdomen so the patient can wake up. I mentioned before the completeness of cytoreduction, and this is an assessment we make after the surgery. And a 0 through 3, as you can see, shows if it's a 0, that means there was no visible tumor left at the end of surgery, and that, of course, is the best option. It means we got an optimal debulking. We were able to get all of the tumor that we could see out. And then 1, 2, and 3, you can see increase in remainder of tumor behind. So 2.5 millimeters or less means it's a CC1. 2.5 millimeters to 2.5 centimeters is a 2, and then greater than 2.5 is a 3. And so the 0 or 1 is really what we try and shoot for, because those are the patients that we know do the best and shows that the best survival long term. In the operating room, trained personnel, not just the surgeon but the whole team, is critical, and so I would perform the surgery, of course, with my assistants. And then the whole operating room staff is critical. So an assistant in the operating room to help me, the scrub nurses, the circulating nurses who get things, the perfusionist I mentioned, the anesthesiologist is important, and of course on the floor, post-operative management, whether it's the ICU or the regular floor, is critical as well. So this is what a picture would look at, and the inflow catheters at the right-hand side of the screen, which sit up near the diaphragm at the upper abdomen, and the outflow catheters, which are at the top of the screen in towards the pelvis, on the left-hand side of the screen. And we close the skin, and then we would, those temperature probes are those white probes that are attached to the end, and we measure the inflow and outflow temperature. And then we agitate the abdomen. This is a picture of the operating room, and you can see the assistant agitating the abdomen to make sure that all the chemotherapy circulates. and the pump is on the left-hand side of the screen with temperature probe which temperature monitors, and then the circulating pump. We keep track of the data because it's important to learn from every patient, and so we keep track of what the diagnosis was and what the PCI score was, et cetera, and how successful the surgery was, so that we can learn on what patients do best, and of course keep track of them. Postoperatively, we of course have to keep a very close eye on patients, and the complexity of that varies depending on the extent of the surgical resection. Any big operation has postoperative issues that need to be monitored, and then in addition to a big operation, patients get a big dose of chemotherapy, and thus we need to keep an eye on both those things. And that's why we look for patients who are generally healthy otherwise and can tolerate a big operation. I'll divide the post-op management into the early, intermediate, and sort of late phase because we want to make sure, because there are different issues that come up at different times. So in the first couple of days, if it's a very extensive surgery, then patients sometimes go to the ICU, and sometimes we even leave them on the ventilator so that they're breathing on a machine to allow their body to heal and not have them stressed with the need to operate or need to breathe on their own, which can be painful and difficult. And of course, we want to make sure that the body's able to heal. There's a lot of fluid shifts. The patients often get very puffy looking, and that can also make the lungs more difficult to take a good deep breath, and therefore sometimes we watch them in the ICU. At a minimum, our patients go to our step-down unit where all of our post-operative HIPEC patients go, which is a slightly more monitored unit with a dedicated nurse who is experienced in this and knows what things to look out for and make the doctors aware of. Fluid status is critical at this time. There might be blood loss during surgery. The ascites, which I mentioned, can sometimes cause fluid shifts after we suction that out. And of course, there's some inflammation just from the trauma of the surgery, but in addition, the chemotherapy, which can be a bit of an irritant to the abdomen. Because sometimes we have to remove part of the diaphragm, which is the muscle that helps us breathe, we encourage what's called incentive spirometry, and that is a way to get the lungs fully expanded, because after surgery, when there's pain, and I should mention pain management is critical, which we focus on quite extensively at Sinai in our program to make sure that patients are comfortable. It's hard to remove 100% of the pain, but we want them comfortable so they can take a good deep breath and sit up in the chair post-operatively, because if not, patients get pneumonia or blood clots, which you can see below, and that can lead to other complications. I often say to my patients that the operation can be the best operation in the world, but if post-op blood clot or a pulmonary embolism or a pneumonia, it can ruin the entire outcome and therefore certainly inhibit it. And therefore we need to be vigilant not just in the OR but out of the OR as well. In the middle to late phase, which would be post-operative day 3 through 4 or 5, something like that, ileus is something which is not uncommon, and that is because the chemo effect on the intestine, the inflammation, and sometimes the bowel resection as well, all can lead to patients' bowel not squeezing well, and therefore it takes a little while for them to be able to tolerate fluids. Once we have them passing gas and having bowel function, we know we can start feeding them liquids and then solid food. Infections might come up then, wound infections or intra-abdominal infections. We keep a close eye on fevers and white blood cell count and things like that are markers. And then finally, late issues. Sometimes patients, they feel they're out of the woods and they're getting ready to go home, but still it's painful. And pain and fatigue are two things that are the last things to recover. Of course, patients go home with pain medicine, but as they start moving around more, being more active, notice more of the pain in the abdomen might come up. And psychological issues are important in that any major operation, it's been well shown, can cause a depression. Of course, it's a serious operation and a serious diagnosis and a lot of issues, and we certainly have social workers on our floor and on Sinai that can deal with this, and of course would facilitate any consultations that were necessary, and I'm quite liberal with that because I think it's an important part to help in the recovery, and certainly patients that aren't motivated and going through all this difficulty, it's hard to be motivated to recover. A little bit about safety. This is an article that was published in the literature a couple years ago, and our data at Mount Sinai, which has also been looked at, mimics this in that there were no mortalities on the study and 1.6% overall. So it can be done safely. There certainly are complications, and no one who does this in any experienced center takes it lightly, but it can be done safely, and patients can return to normal quality of life postoperatively. I'll end with the last number of slides to show the Mount Sinai experience. I started the program in July of 2007. Since that time, we've done 121 patients, and we use the standard surgical technique that I just discussed. All perfusions were done with a closed. That's the technique I showed, though some people might read about an open or Coliseum technique. We don't use that, and most centers don't. For the data that you're going to see, mitomycin C is the most common drug, but there are sometimes a few other different drugs that we use based on the primary diagnosis. You can see these are the different types of cancers that have been looked at in our series. So colon cancer, appendix, and pseudomyxoma are definitely the majority, but stomach cancer, some sarcomas, which are other types of cancers that can be in the abdomen, gallbladder, small bowel, and of course these are just select cases that are appropriate. It's not for everyone with this diagnosis, but in certain select situations. The demographics, you can see the number of procedures, and you see the number is higher because we actually do and have done a number of patients where we do a repeat HIPEC, which is possible. Of course, we wouldn't do that, 1 week later or even a few months later, but if a year or many years go by and it's appropriate, then we certainly can repeat HIPEC once and even more than once. Most patients have had previous surgery and previous chemo. It's a fairly even ratio, and you can see the median age, or the mean age is 55, but there's a wide range. The asterisk 2 of 2 patients that didn't get perfused were patients who were opened for surgery but were unable to have surgery based on the extent of disease. You can see the number of procedures done, and these are the number of organs resected. You can see when I say organs, that includes the diaphragm or omentum, which are fatty tissue in the belly and not quote-unquote necessary, but you can see these are extensive operations with the majority having a significant number of areas removed and having the intestine put back together. Our patients have a range of PCI in the area of 17. You can see this wide range here, but this is where the average is, and of course some patients have more disease than we expect and some have less, and so we have to make an assessment. The majority of patients have R0, R1, which is only visible or microscopic disease. All visible and disease is removed or just microscopic left. And you can see certainly 2/3 or more have an optimal debulking. And so that's sort of the range we want to go with. We don't want to have everyone having an optimal debulking because then perhaps we're excluding people that might be possible, but we have to make sure we don't want to be taking patients to the OR that aren't going to benefit from it. Overall, there's only been 1 death in our series, so it's 1 or less than 1%. This is within 30 days. Complication rate is high, but most are in the setting of wound infection and non-life-threatening complications, with most patients staying about 8 days, but of course some have stayed longer in this wide range. And the hematologic complication, which can come from the chemo, again, highlight the benefit in that chemotherapy going around the whole body can cause a lot of issues with bone marrow and with the ability to make white blood cell count and fight infection, and doing the chemotherapy in the belly at a high concentration spares the rest of the body. In looking at our last follow-up, you can see patients without any evidence of disease is about 33% of our series. Of course, this is across all the different histologies. Some have passed away from other reasons, some have passed away from progression, and most are alive with disease getting some treatment. But it shows a good effect on patients who really were living months before, only less than a year, and who are doing well. So I'll conclude with a summary that HIPEC is an aggressive treatment option for patients, but appropriate in many settings. Rigorous preoperative testing is important to make sure we're doing it on the right patients in the right time. Coordinated program is also very important in that we want to make sure we're doing this in a place that's experienced and that can anticipate not just the intraoperative issues, but postoperative and otherwise. and of course, further studies to optimize the long-term outcome are constantly ongoing. I'll end with this quote, which is from a medical oncologist, not a surgeon, which really speaks to one of the more promising things, and this was about 6 years ago now that it was said 7 years ago, but really speaks to well in that the cytoreductive surgery and intraperitoneal chemotherapy may be, and I think is really proven to be, one of the most exciting new treatments. And it doesn't mean it takes the place or is instead of regular chemo, but it really offers a new option to patients that before didn't have that. I'll end with this slide. If patients have any questions or certainly want